Hello everyone, my name is Sarah Otto and I'm going to be discussing the following presentation, which is part of our group behavior change project, in which we're going to discuss the study that we attempted to replicate and the surrounding literature. We decided as a group to focus on adult student health and the consistent use of multivitamins. So some past research in this area shows that increasing medication and or vitamin use adherence has the potential to reduce healthcare costs while improving care quality, patient satisfaction, and health outcomes, as stated in the article Medication Adherence Process for Implementation from 2014. The hard part of adherence is actually remembering to take a medication. In a world where we are so often balancing tons of different things, it can be really easy to forget if and or when we took a necessary medication or vitamin. Stress, especially among college students, may also be contributing to the overwhelming feeling of having to remember just one more thing. So stress can become so unmanageable that it actually snowballs into larger problems and can result in a lack of rest and productivity, and that just leads to anxiety, tenseness, and even sometimes depression. The article Medication Adherence Process for Implementation from 2014 sought to address processes for implementing medication adherence interventions with the goal of better informing providers and healthcare systems regarding the safe and effective use of medications. So this really looked at key components of medication adherence, really being the patient, the provider, and then the practice, which can all contribute to higher levels of faithfulness. So providers can help by making sure that medication protocols are simple and they're concise, they're easy to follow. The article also went on to discuss that training in the areas of health literacy, motivational interviewing, and informational technology is useful for healthcare professionals to help educate and support their patients. The patient also contributes to the success of this by remaining an active participant in their health and remaining in contact with their doctors before, during, and after care has been established. The practice, which is also known as a healthcare system, contributes to the triad of success, and that they are responsible for providing support for patients and making sure that all the patients remain satisfied with their level of care. So this leads me to another article that used a cross-sectional survey with nurses working in internal medicine, cardiology, and medical surgery to determine the nurses' attitudes and behaviors regarding the provision of patient medication education. So these nurses had reported various methods of attempting to increase medication adherence, including motivational interviewing, the teach-back method, offering pill boxes and reminders, and then providing written materials to both patients and their families, as well as a 1-hour educational session. The results of that survey found that over 90% of nurses who completed the survey found it important to provide patients with information regarding their medications and medical conditions. In another 2016 study conducted using 92 bariatric patients 6 months post-surgery, researchers examined vitamin supplementation bariatric aftercare, as it's obviously recognized as an essential component of preventing nutrient deficiencies. So the study was completed using a questionnaire to gather various information about those patients, such as their demographics, their psychological scores, and then their adherence according to self-reporting from those participants. The self-reports of medication adherence were scored using the Morinsky medication taking adherence scale, as well as the visual analog scale. In addition to nutrient deficiencies being evaluated using serum vitamin levels, all of that was assessed, measured 3 and 6 months after surgery, and the study found that there were really no significant factors contributing to that non-adherence that were statistically relevant, aside from the non-adherent participants being primarily males who were full-time employed. Additionally, the article Effect of an Educational Program on Adherence to Therapeutic Regimen Among Chronic Kidney Disease Patients Under Maintenance Hemodialysis examined how poor adherence can really be a serious risk to health and the well-being of a patient. The medication adherence is obviously imperative in ensuring the management of these diseases and deficiencies. So the researchers in this study sought to establish whether or not an educational program which served as their intervention would improve medication adherence. They secured a sample of 60 adult male and female patients on maintenance hemodialysis for at least 6 months, but no longer than a year. As stated by the researchers, the design of this study included a pre- and post-test quasi-experimental research design. This results found that females demonstrated higher levels of adherence than males, and educational level also seemed to play a role, as individuals who had completed postgraduate coursework were more likely to follow their regimented medication schedule. So with all of this said, I'm going to pass this along to Emily so she can further discuss our original study.
Okay, so our original study was by Rafe, Jarvis, and Dallery, and the title is Text message reminders plus incentives increase adherence to anti-diabetic medication in adults with type 2 diabetes in 2016. So this article guided the purpose and procedure for our current study. They recruited 3 participants living with type 2 diabetes, and their purpose was to increase that adherence to the anti-diabetic medication. The researcher was able to gear up a text message reminder system to send to the participants' phones, which would immediately remind them if the pill device hadn't been opened up during their specific window of time. They were able to give a monetary incentive if the participants did follow the procedure, and that was basically the combination treatment package for that study, a text message reminder and a monetary incentive. So the researchers were able to recruit participants from the endocrine doctor's clinic that a lot of diabetic patients visit. They had to be between 30 and 75. They had to have a phone that received text messages. They needed type 2 diabetes diagnosis and have an oral anti-diabetic medication they took 2 times a day for at least 3 months. They would have had to miss a dose in the last 7 days, have an A1C value of 7 to 10%, no mental health diagnosis, or they couldn't be currently pregnant. And they were able to find 3 different participants that met that criteria, a female Caucasian, a Caucasian female, and 2 African-American men, age range between 42 and 51. So before the study began, they trained each of the participants to use the Y-Spell dispenser and involved them in the study procedures so they knew what to do. They asked them to set a specific time window to take their medication, and they explained the escalating pay schedule with the bonuses and contingencies that were going to be used as the intervention. Basically, every time that you took a pill successfully, the amount of money you earned went up. But if you missed a pill or you didn't take it within the specific window, you had to start all over. So participants received text messages each morning indicating how much they'd earned the previous day, how much they would earn that day if they continued to be consistent. So they used a non-concurrent multiple baseline design across participants, and during the baseline condition, participants were to use the Wise Pill dispenser to take their pills, but they did not receive a text message reminder or any monetary incentives. And during the intervention phase, they continued to take the pills through the Wise Pill dispenser. They received text message reminders, and they were able to earn a monetary incentive. The baseline lasted between 8 and 12 days, and the intervention was 21 to 23 days, just depending on the participant. So the data showed that participants frequently failed to adhere to their medication routine, but once the intervention was put in place, their success rate was anywhere between 71 and 95%. So there was an obvious increase in their adherence to their medication. And the intervention was able to send out 38 text message reminders to the participants overall, which means that the intervention was used. The text message reminders were sent out, which means the participants were forgetting, but the intervention was able to increase their success rate. The limitations that the previous authors of the original study stated were that it was hard for them to separate the effects of the treatment package because it was a combination of 2 variables, the text message reminders and the monetary incentives. So it was hard for them to decide which one of those was gaining the most effects because it was a treatment package. They also realized that the medication was being indirectly measured because it automatically checked taken as soon as the Wise Pill dispenser was open, but that doesn't mean that the participant actually took their pill, as well as the intervention phase was quite brief, especially for a population with a diagnosis of diabetes, which is a very long-term medical condition. The authors would have wanted a longer intervention phase so that they could understand the interventions long-term. So the purpose of our current behavior change replication project is to determine if we can systematically replicate that previous study based around adult students taking a multivitamin rather than an anti-diabetic medication. So basically our results successfully would be to have an intake of a vitamin or medication with prompting to maintain a proper intake. So to do that for us as a population, we had to make multiple adaptations to the original study. So we changed the medication from an anti-diabetic medication to a woman's vitamin that was taken once a day. Our intervention phases were shortened. The first condition was 5 days. The second condition was 3 days versus 8 and 21. The participants ourselves used the Round Health app instead of a Wise Pill dispenser, and we were rewarded daily based on our own individual choices. So a lot of us chose treats or edibles, and we were able to measure both IOA and treatment fidelity, which wasn't mentioned in the original study. So I'm going to pass it off to Olivia so she can talk to you guys about the methods section.
All right, so for our study replication, there were 5 female participants between the ages of 24 and 27 years old, all of whom are currently enrolled in an online graduate program at Ball State University. All participants identify as Caucasian, live in North America, and have no other diagnosed medical conditions. 3 of the 5 participants did report taking at least 1 doctor-prescribed medication daily, and so for these participants, they continued to take that medication throughout the course of the study during both baseline and intervention phases as needed. In terms of the setting varied daily for each participant. It was at home, at work, in the car. It was really a matter of what was most convenient for each participant each day. So in terms of materials, there were 3 main materials that were used. One of the first ones was the Round Health app. And so this was an app by Circadian Design, and it's an app that tracks daily medication adherence. And so you can see here, this is what the app looks like in the App Store. It's only available through Apple and iOS, so anyone with an Android or other form of phone won't be able to access it at this point in time. Participants also had to have access to a daily women's vitamin, and this was of their choice. So 4 of the 5 participants took gummy form, whereas 1 took a pill, and there were various brands that were used just depending on what was available to each participant based on where they were located. And then, as Emily mentioned, each participant also chose a reinforcer of their choice that was used particularly during the intervention phase. So the behavior of taking a vitamin was defined as each instance of a participant orally ingesting a vitamin by placing a vitamin in their mouth and swallowing it. And we recorded, or we took data on this behavior through the use of frequency. And each participant recorded whether or not they took their vitamin within each 24-hour period. And so this is an example of our data collection sheet that for each session, each participant marked yes, the vitamin was taken, or no, their vitamin wasn't taken. And then this allowed for the adherence percentage to be determined during baseline and intervention phases, which will be later discussed in the results section. So we used an AB reversal design for this study replication, and this allowed for the behavior to be measured across alternating baseline and intervention phases. So we started in baseline, moved to intervention, back to baseline, and then intervention a second time, and this helped determine if there was a functional relationship between the dependent and independent variables. So in terms of what baseline and intervention phases actually looked like, baseline was collected for each participant's adherence to taking a woman's daily vitamin. And during these baseline phases, participants received no reminders to take the vitamin, and they also didn't receive any form of reinforcement contingent on adhering to taking their vitamin. So it was upon each participant to self-monitor their taking of their vitamin and track this using the data collection sheet previously referenced. And again, this was if the vitamin was taken at any point throughout the day. The initial baseline lasted 5 days, and this was based primarily on the stability of the data, while the second baseline lasted 3 days, and again, that was primarily due to time constraints for the purpose of replicating the study. During intervention, each participant took the same vitamin that they took during baseline. However, during intervention, participants received reminders through the Round Health app to take their medication. And timing of the medication administration wasn't as pertinent as long as it was taken within the 24-hour period each day. And so through the Round Health app, the vitamin was able to be added in terms of its name, its dosage, its frequency, and then each participant was able to select a time frame within the day that they'd like to receive alert or a reminder to take their medication, and this allowed for it to be adjusted based on when it was most convenient for each individual. And then they were able to check off, in addition to the data collection sheet, they were able to check off on the app whether or not the vitamin was taken during those intervention phases. And so during intervention, participants also earned a daily personally identified reinforcer. And so for all 5 participants, it was an edible of choice. So it was a Hershey Kiss or a Jolly Rancher or a Timbit, something simple, but reinforcing enough for taking the vitamin during intervention. And again, participants documented saying, yes, the vitamin was taken, or no, it wasn't. And as you'll see in our results section, rather than individually compiling our data, we did compile our data as a group, looking at all 5 participants within each session and whether their vitamin was taken or not. Then finally, when looking at inter-observer agreement and treatment fidelity, these were both reported during 30% of the sessions. And so for IOA, trial by trial IOA was used. And basically participants videotaped or video recorded themselves taking the vitamin. And then they shared this video with other participants in the group. And so participants communicated primarily via a group text message. And so participants would send their video via text message, and then it kind of rotated in that participant 1 would be the secondary observer for participant 2, 2 for 3, 3 for 4, and so on, so that there was a primary observer and a secondary observer for each video, allowing for IOA to be collected. And so as you can kind of expect, we had 100% IOA, and that was primarily due to the fact that if I were to take a video of myself taking a vitamin and send it to Emily, Emily wasn't going to look at that same video and say, nope, she didn't take her vitamin. And so the videos that were sent were of us taking that vitamin. And so as a result of that, IOA was 100% for this study. And then finally, looking at treatment integrity. Again, this was completed during 30% of the sessions, and this helped us ensure that we were implementing intervention consistently and as designed. And so the 2 main steps when completing the intervention phases were, did the participant utilize the Round Health app, and did they have access to a personally identified reinforcer? And so during these sessions, when treatment integrity was being recorded, participants would either indicate, yes, the step was utilized, or no, it wasn't. And so looking at the total number of steps for each participant did come out with 100% treatment integrity. And so that was for each individual, and across the group, there was 100% adherence to those steps. So Shelby is now going to talk about the results of our study.
So as Olivia had previously mentioned, we did graph all of our data together just to see a more vast data collection and be able to see a more useful relationship between the variables. If we had done it individually, it would not have shown as useful of a relation. So the graph shows that we had our best adherence during baseline 2 and our lowest during intervention 2. Figure 1 shows that all 5 participants in the study were already fairly consistent with taking their vitamin during baseline and then again during intervention, scoring between 80 and 100% over the 2 5-day sessions. Then in baseline 2, there was 100% adherence, and in intervention 2, there was a low point where we had 60% adherence to the medication, leaving us at 96% overall for the second intervention, and then 80% overall for the second intervention. I'm sorry, it was for the first and then the second. And that's all. I'm going to pass it on to Heather to talk about the limitations of our study.
So as we were going through the research and replicating this study, we found several limitations that we thought were worth noting. The first one, which was probably the most crucial for us, was limitations and difficulties that we experienced due to us being both the experimenters and the participants in the study. Because of this, we felt like we were probably a little bit more mindful of what our goal was and what we were trying to replicate. And that might have spoke to the high adherence during our baseline phases because we were more aware of our goal to take the medication. And as it was mentioned earlier by other group members, during our baseline phases, we were not supposed to receive any sort of prompts or reminders to take the medication. But due to being the experimenter as well, we were working on other components of the project and discussing other aspects throughout the time when we were collecting baseline data. So some participants might have received informal, unintended prompts because of us talking about other components of the research project. Another limitation that we experienced and was also noted in the original study was the duration of the intervention phases. We didn't have a long time to take the medication. In the original study, the medication that was being taken was diabetes medication, which would be a medication that you would take for a long duration of time. It wouldn't be something you're just prescribed for a few weeks or even a month. So long term, you would have to find a way to sustain taking the medication because the monetary incentive that was used in the original study and then our edible reinforcement that we gave ourselves in our study probably couldn't be maintained in the long run. An additional limitation that we discussed and we noticed throughout was the fact that a vitamin is not necessarily a critical medication. So as opposed to a diabetes medication, which you would probably have pretty immediate health issues if you didn't take it, a vitamin isn't providing you anything immediately towards your health. So we felt like we were maybe a little less motivated and it wasn't quite as critical to take it because we knew that nothing was immediately going to happen to us if we didn't take the vitamin. And then finally, a limitation that we experienced multiple times and was again similarly mentioned in the original study was some flaws with the application that we used. So in our replication, we use the Round Health app. Similarly to the Wise Pill device that's used in the original study, you get a notification that says it's time to take your meds, and then you can just click I took my meds and the notification goes away. So we felt that it was kind of easy to just click that to get it off of your screen and continue to go about your day and not necessarily have taken the medication at that time. Similarly, in the original study, you could open the Wise Pill device and it recorded as taken even though the participant didn't actually take the medication. So future research would probably want to look at a way to track the data that's collected from those applications versus some real-time data from the participants. I'm going to pass it back to Shelby so she can wrap up our conclusion.
So in conclusion, the data showed that participants maintained a slightly increased stability after adhering to the prompting app. Unfortunately, this data cannot show a functional relationship as the students' researchers already knew of the routine medication intake, and all the students were balancing a full schedule with multiple aspects of daily life, including family life and school. And future research in this area should concentrate on determining the importance of incentives and strengthening the reinforcement for adults to maintain their daily vitamin regimens. Researchers should also take interest in the possibility of using different types of apps or a more effective way to measure real-time data. And that's all we have.
Okay. That's the first time I've had a group do this study for the replication project, so I thought it was really neat. How much time do we have right now left?
It doesn't tell us.
We don't have a warning yet, so that's a good sign.
We started at 7:15, and we have, I think, 40 minutes from after that. So,
Okay, so I think we're
10
good.
minutes.
10 minutes, yeah.
Oh, it says 10 minutes. Yeah. Okay, that's perfect. So I thought that was a really good presentation. And what I like was how you guys were able to make some modifications to the replication project in order to make it work, as a replication. And you guys did a nice job sort of highlighting the differences between the replication and the original study. One question I did have was, so you have pretty high baseline data originally, and then you've got, can someone put up the graph for the group? Okay. And then you have a slightly higher intervention data. Then you have very high return to baseline data. And then there's some more variability in that intervention. I'm just curious to know, for that 60% of adherence in the second intervention phase, what happened? Can any of you guys remember, like, why you may have forgotten to take it? Yeah.
I was traveling between Florida and Illinois a lot during that time, so I just missed a day here and there, to be honest. And there were other factors, I feel like, as far as like health-wise, that kind of contributed to me being like, oh, I need to remember to take this. And I would have my pills with me, but I would completely forget to take them because I was traveling so much.
Okay. Anyone else?
Yeah, we kind of discussed, like, as a whole, the app reminds you, and then you can just click off. So I found myself clicking off during the day, like while I was at work, when it reminded me, especially because my window was from 11 to 1, and usually my lunch is at 12 o'clock. So I was going to take it at 12 and I would just swipe it off. And then I forgot on some days after I would swipe off during a busy period at work or something like that.
It's very interesting, because it's like you had 100% adherence in baseline, and yet with the intervention, that second baseline, and then with the intervention in place in that second intervention phase, the adherence was like slightly lower, where you almost wonder if the application may have been throwing you off when you're, without having anything, like you could have it become your nighttime routine or whatever, and there could have been, I'm just trying to think of, some of the possible reasons why you might have had better adherence in that second baseline phase. So I do think what you guys mentioned just now should be some things that you point out in the limitations too, in terms of like other variables that may have contributed to a little bit of that variability in that at least the second intervention phase. You guys did a good job mentioning that you really can't demonstrate a functional relationship. I forget what the reason was that you guys said it was the case, but I would really emphasize when you talk about the functional relationship, it's due to the high baseline data in really both phases. So you have a bit of a ceiling effect in the first baseline phase where you have such high adherence for the most part that you're going to have very little room to improve in the intervention phase. And then in the second baseline phase, you had 100% adherence for all participants. So it did not decrease, that adherence did not decrease back to even the original baseline levels. And so that's where I would like really hammer, like as your explanation for not demonstrating that functional relationship. And what else did I want to mention? The rationale for collapsing all the data together. I think you guys mentioned it as it wouldn't have been as useful of a functional relationship or something like that. But I think when you're doing the write-up, one important thing to do, which I've had groups do before, is really try to pinpoint how the replication is going to deviate from the original study and why. And so, when you're talking about the data collection, you guys can mention that they looked at the adherence, but it wasn't taken within a certain time frame, and was it delayed for each participant? But for this, because it wasn't a time-sensitive medication, the window was a 24-hour period, and the data were analyzed for the group as a whole, or something like that. You want to provide that rationale because it didn't matter. We talked about this when we met before. Like, if it's taken, within a certain time frame. And so I think that gives you a good rationale for why you changed the data collection and how you portrayed it and graphed it for the replication project. So I think that may be about all of my main points. I thought that you guys did a good job describing the IOA that you collected. It was very straightforward, as well as for the treatment integrity. I mean, you had a pretty simple intervention in place with only the 2 steps, but I'm really glad that you guys added that, because even if you've noticed, a lot of studies might not include it.
Yeah.
And so it gives you some good practice with really understanding that whole concept that we're trying to measure the treatment if it's implemented as it's intended. So I want to open it up for just a couple more comments. If you guys were to do this differently, if you were to do it over again, perhaps what would you have changed about the project?
I think when we were talking,
I think I would have changed how we tracked I'm sorry.
Sarah, go ahead. You go first.
I think I would have changed how we tracked taking the actual multivitamin or medication, just because, like everyone's kind of mentioned, it was so easy to kind of be dismissive and check it as being completed, and there wasn't any real way of doing like a fidelity check on that to see if it had actually been done.
A lot of it was on the honor system, right? Because it was also like the only ones that you recorded were for IOA purposes.
Right.
Correct. Okay.
Yeah.
And Emily, what were you going to say?
We were talking a lot about how we would change the reinforcement for taking the pill, whether we were going to do, a reinforcer or a punisher. And we were really trying to think, like, is a punisher the way to go? Because, we want to use that as a last resort. We were thinking maybe having like a bank of money that the total that you could earn and having to give money back if you missed a pill, or we were trying to think of different ways that, because we know it's not the medication that we need to take, it's more of a multivitamin as an additional support to your health. So we were trying to think of a way that the reinforcer would be strong enough to take a vitamin that isn't really required. And so we were thinking more along the lines of going back to the monetary incentive versus an edible, but we still really didn't know how we could make it work with a strong relationship.
Well, and because you had such high adherence, it's going to be hard to really improve your outcomes, because you had actually pretty good adherence in the intervention phases. I think one thing that's also worth mentioning in the discussion is, because you guys collapsed all your data together, you could consider a group contingency. For if you had adherence over a certain amount each day for the entire group. And there are different types of group contingencies that can be put into place, which wasn't done in the original study because it was all individualized. And you could have kept with an individual reward, which you guys did. But sometimes it's also interesting to see if the adherence level is above a certain criterion for the entire group, and having some sort of reward in place for the group, or the group doesn't earn it if you don't have adherence for everyone. So that's just a couple things to think about for the write-up. And then also maybe the different applications that could be out there. One that might be a little bit better to use than the application that you guys ended up going with. And I would definitely mention the limitations you guys came up with based on that application. But overall, very nice presentation.